about cyst of the jaw. In this lecture, we will discuss about the various cysts, the definition, the classification, and its management. So these are the contents in which we will be discussing the definition, classification, pathogenesis of various cysts, clinical examination. Then we will separately discuss about the odontogenic cyst and inflammatory cyst, and then management. So Killian K defined cyst in 1966 as a cyst that constitutes an epithelium-lined sac filled with fluid or semi-fluid material. Fit for odontogenic and fissural cyst, but about solitary and bone cyst or stagnous cyst, the definition doesn't holds true, as these cysts are actually empty, or there is no content inside the sac, and these cysts are not lined by epithelium. So Kramers in 1974 redefined cyst as a pathologic cavity having fluid, semi-fluid, or gaseous content that are not created by the accumulation of pus frequently, but not always is lined by epithelium. So by this definition, we understand that cyst is a cavity which may have content such as fluid, semi-fluid, or gaseous content, and it is not created just by it is not created by accumulation of pus, and it is most of the time lined by epithelium, but the epithelial lining the epithelium lining is not always present, or it is not present in all types of cysts. Classification, the various classifications are based on various factors, which was given by Robinson in 1945, Thoma and Robinson Bernier in 1960s gave another classification. Kruger gave his own classification in 1964. WHO lined the classification of cyst in 1971, and Scheer classified cyst in 1983. So according to Scheer, which is the most accepted and most read classification, the cyst of jaw is associated with maxillary antrum. Cyst, he defined classified cyst as cyst of jaw and cyst associated with maxillary antrum, and a third category as cyst of soft tissue of the mouth, face, neck, and salivary glands. So odontogenic cysts include odontogenic keratocyst, dentigerous cyst, eruption cyst, gingival cyst of infants, and gingival cyst of adults. Developmental lateral periodontal cyst, botryoid odontogenic cyst, glandular odontogenic cyst, calcifying odontogenic cyst. And amongst the non-odontogenic category, Scheer classified mid-palatal raphe cyst of infants, nasopalatine duct cyst, and nasolabial cyst amongst the non-odontogenic cyst. Then amongst the inflammatory cyst with inflammatory origin, radicular cyst, apical and lateral cyst, residual cyst, paradental cyst, and juvenile cyst, and inflammatory collateral cyst are included in inflammatory origin. Then amongst the non-epithelial lined cyst or pseudocyst, solitary bone cyst and aneurysmal bone cyst lie in this category, along with traumatic bone cyst and hemorrhagic bone cyst. So cysts associated with maxillary antrum include mucocele, retention cyst, pseudocyst, and post-operative maxillary cyst. Then amongst the third category, cyst of soft tissue of the mouth, face, and neck, dermoid and epidermoid cyst, brachial cyst, thyroglossal duct cyst, anterior median lingual cyst, oral cyst with gastric and intestinal epithelium, cystic hygroma, nasopharyngeal cyst, thymic cyst, cyst of salivary glands, and hydatid cyst are included in the cyst of soft tissue. So now coming to the pathogenesis of the cyst, the formation of cyst takes place generally by three phases. The first is the initiation phase, second is it is followed by formation of the cyst, and third stage is the enlargement or expansion of the cystic cavity. So what is initiation of the cyst formation? Mostly it is initiation of cyst formation mostly from odontogenic epithelium is seen, and stimulus which initiates this process is mostly unknown for the cyst, and the Proliferation of epithelial lining, fluid accumulation in cystic cavity, and bone resorption are the two main factors that results in the cystic formation. Then cyst formation, is lined by stratified squamous epithelium, and Shear in 1963 and Tenkate in 1972, Harris in 1974, and Walderhog in 1974. They explained their separate theories of cystic formation. So, if a cleft produced by accumulation of purulent exudate in form of a microabscess is involved, one of the proliferating strands of epithelium, then the epithelial cells would be expected to line these clefts. Another mechanism includes epithelial cells become oriented in relation to their source of nutrition and the adjacent connective tissue. In normal situation, they cover a surface and finally desquamated. If the proliferating epithelium beneath the surface, as seen in granulomas, cells will migrate inwards and desquamate in the center of this mass, thus producing a fluid-filled cavity. Now, coming to the enlargement of the cyst, the mechanism for the enlargement is similar, but additional factors are involved, such as attraction of fluid into the cystic cavity, retention of fluid in the cavity, and then production of raised internal hydrostatic pressure and resorption of the surrounding bone with an increase in size of the bony cavity. In 1974, Harris classified theories of cyst enlargement. And amongst the neural growth theory, the peripheral cell division occurs and accumulation of the cellular content causes the expansion of the cyst. And according to the hydrostatic enlargement, there are secretions, then transudation and exudation within the cystic cavity occurs, and bone resorption occurs with the help of the bone resorbing factor, which resorbs the surrounding bone outside the cystic lining, and this results in expansion of the cystic cavity. The clinical examination of the cyst depends on the diagnostic features, symptoms of the cyst, signs of the cyst, clinical stages of cyst, secondary effects on jaw, and investigation. Diagnostic features include dimension of the lesion, type of the cyst, location of the cyst, important structures adjacent to the cyst, and presence of infection in the cyst. Symptoms include pain and swelling, salty taste, difficulty in mastication, ill-fitting denture, displaced teeth, and space between the teeth. Sign of cyst also includes bone expansion, fluctuant swelling under the oral mucosa, non-vital tooth if radicular cyst is present, missing tooth or displaced tooth, sinus formation with discharge, large cyst, a distortion of adjacent structure will be seen, and hollow sound on percussion will be seen, which is called as eggshell crackling sound. Clinical stages of cyst include periosteal stimulation, which includes curved enlargement of the bone, then tennis ball consistency may be seen, and eggshell crackling is seen, that is micro cracks on the cortical plate. Fluctuations due to complete resorption of the bone overlying the cyst. Sinus formation may be seen, and infection due to contamination from the oral cavity may be there. Secondary effects on jaw due to cyst is the numbness, pathological fracture of the jaw, secondary infection, and malignant transformation. Investigation includes radiographic examination including CT scan, contrast studies, aspiration test, vitality test of the tooth, and biopsy. So the dentigerous cyst is